the second one. We did Jared's malaria one last week. So Lyle's going to be talking to us about Staph aureus bacteremia, and I think this is an extremely important topic, and one that is often moderately mismanaged. I think people don't realize what, the severity of Staph aureus bacteremia and the implications, and also the degree with which it needs to be worked out. I think there's some people consider that an echo is always necessary, and some people never do an echo, and so on. So I think this is a useful topic, and we and it's going to be of benefit to our clinical practice. So off you go, Lyle.
Thanks, Sarah. Morning, everyone. So today, I'm going to be going over a few important aspects of Staph aureus bacteremia. First of all, why we make such a big deal about it, how we should investigate it. Is an echo really necessary? As Sarah mentioned now, should you consult ID? Is there any value at all in consulting us? Clox versus cefazolin is a big question, particularly now where we have shortages of clox. What about MRSA? How do we treat patients differently if they're methicillin resistant? What about oral therapy? Can we use oral therapy for Staph aureus bacteremia? Some of that evidence is changing. And then we'll go through a little mnemonic as to how we can try and remember some of these important issues as a kind of checklist as part of, and we call it lime and soda. Okay, so why is Staph aureus called Staph aureus? Well, Staphylococcus is derived from the Greek term staphyle. That means a bunch of grapes. Coccus, means a round bacterium. And so, and also aureus comes from the term aurum, which means gold. So you put this all together, it's gram-positive cocci. It's also catalase positive and coagulase positive. So if you look at this basic description of all gram-positive bacteria, which obviously leaves some off, if we divide them up into bacilli, cocci, within the cocci, we've got catalase positive, which would be the staph. And within that, you've got coagulase negative staph and coagulase positive, which is the most important, the Staph aureus down there in the corner. This is what it looks like on a gram stain. See gram-positive cocci in clusters is what you often see reported from the microbiologists. And this is what it may look like on a blood agar plate, and you might not be able to see clearly, but it's got a kind of goldish hue. That is why it's called Staph aureus. And so if you put this all together, you can imagine why someone may describe a review on the topic as the golden grapes of wrath. If you just understand basically why it's called Staph aureus and the clinical implication of the Staph aureus bacteremia in the blood culture. So where is Staph aureus generally found? It's generally found mostly in the human nose, also found on the skin, so also in the vagina, pharynx, axilla. About 30% of the population are colonized, and this is much higher amongst healthcare workers, so all of you, and patients. And those patients that are at higher risk of colonization are those with any other comorbidity, so diabetes, particularly patients with renal disease who are on dialysis, patients who are admitted with IV, who use intravenous drugs, and our HIV positive patients as well. And so transmission occurs via direct contact, so most of the time through contaminated hands. So that's us not really washing our hands between patients in the hospital. And also can survive on some surfaces as well. And that's why you may get hospital outbreaks, so particularly in high dependency units like burns units and neonatal ICUs and medical ICUs. Why is it so virulent? Well, there's a whole lot of different virulence factors that are produced by the bacterium. Enterotoxins, staphylococcal enterotoxin A to E. So there's also further G to J. Some of them like staphylococcal enterotoxin B is referred to as a kind of super antigen that can stimulate all sorts of immune cells, including your lymphocytes. There's cytolytic toxins, including your leukocidins, one of which is the panton valentine leukocidin. And then your exfoliative toxin as well, which is involved in Staph's called skin syndrome. Enzymes as well, staphylocoagulase, hyaluronidase, protein. So lots of different virulence factors that play a role in establishing and also allowing significant disease when infected. So what kind of clinical manifestations is associated with staph? I mean, you know that it can really affect mostly soft tissue and skin. And this can be divided up into your kind of cellulitis, erysipelas, and pyomyositis soft tissue infections, as well as your primary pyodermic infections like your impetigo, folliculitis. But also basically can affect any organ in the body. So endocarditis is quite common. It can also cause a pericarditis, apparently pericarditis in the lungs, can cause pneumonia or abscess or epyema. We know bone and joint can be affected. CNS can be infected with brain abscesses or meningitis, and of course bacteraemia, which is the main topic of today. You can also look at specific toxin-mediated conditions like the staph scalded skin syndrome, toxic shock syndrome, as well as the food poisoning associated with staph, some of the staph enterotoxins. And one of the important things about these enterotoxins is that they're stable at quite high temperatures. So even on heating or heating food to quite high temperatures, you may not be able to get rid of the toxin, and can cause a very violent gastroenteritis. So staph aureus bacteremia, what is it? It's very simple, really, just the detection of Staph aureus in the blood culture. So I just wanted to ask everyone, just briefly, to put up your hands in terms of, if you get Staph aureus bacteremia on the blood culture, what proportion of those may possibly be a contaminant? So these are the options. So 30%, put up your hands if you think 30% would be a contaminant. No one? 0.1%. Okay, we've got 2, 3, 55%. Okay, that's quite high. 80%. 5%. Wow, that's pretty. So the answer is 5%. So the point is that basically it's very seldom that a Staph aureus blood culture is actually a contaminant. That's different to, say, a coagulase negative staph, which is obviously much higher. So it's important to remember to always take a Staph aureus blood culture seriously. So there's this study that looked at the significance of a single positive blood culture. They took a group of patients that had multiple blood cultures taken at one time, and those that had a single blood culture versus those that had multiple that were positive. And overall, out of these 500 patients, about 100 had single positive blood culture, and of those, 90% of them was considered clinically significant. So this is about 10%. So in the region of most studies are between 5 and 10%. Why do we make such a big fuss about Staph aureus bacteremia? Well, one of the things is it's the second most common cause of a bacteremia behind E. coli. It's quite a high incidence. Hospital mortality is high in the developed world, between 15 and 40%. In our setting, was probably a bit higher. And that quite frequently, Staph aureus bacteremia is complicated by metastatic infection, so other secondary complications, endocarditis, osteomyelitis, and if you have any implant or prosthetic material infections there as well. And importantly, management is different to Staph aureus as to how it would be for, say, an E. coli bacteremia. This is some local data from Curtis Cape Town. They had about 100 patients with Staph aureus bacteremia. 30% were community acquired and the rest were hospital acquired. Their 90-day mortality was 47%. So 1 out of 2 patients died within 90 days if they were diagnosed with Staph aureus bacteremia in a basically tertiary quaternary level setting. What was associated with death? Well, none of this was statistically significant, and maybe you may not have seen that, but MRSA was associated with a bit higher mortality, although, as I said, bordering on significance, but not quite meeting criteria, and also having other comorbidities as well. They repeated the study a few years later, looking at a particular intervention at managing the Staph aureus bacteremia, and in that study, they had reduced the mortality rates to about 1 in 5, so about 18%. So still really, really high. An important concept is complicated versus uncomplicated Staph aureus bacteremia, and I'll explain why that is. It mainly relates to searching for complications as well as to duration of treatment. So generally, uncomplicated Staph aureus bacteremia would be where there's no evidence of endocarditis. There's no implanted foreign bodies. Blood cultures are negative after about 48 to 72 hours. And there's no evidence of metastatic infection. Patients get better within 48 to 72 hours of treatment. So that would be termed uncomplicated. Obviously, complicated is everything that's not uncomplicated. And here I'm mentioning some of the odds ratios associated with some of these characteristics. Odds ratios of mortality. So blood cultures that are positive after 48 to 72 hours on treatment, patients who've got Staph aureus bacteremia from the community, fever for prolonged period, skin findings associated with systemic infection, and then persistent infection, so or basically absence of source control. Endocarditis, obviously, and then there's a few other factors that are loosely associated, such as older age and also, as I mentioned before, MRSA. So what risk factors are associated with poor mortality or poor prognosis? I mean, obviously all the factors that are associated with complicated Staph aureus bacteremia, but this particular study looking at a particular kind of breakpoint in duration of bacteremia and poor outcomes. And if you look at this graph, there's mortality on the left, and there's days of persistent bacteremia on the bottom axis. And you can see that for every increased day in duration of bacteremia, there's an increase in mortality. There's also an increase in metastatic complications, 30-day mortality, and length of stay. So basically, for every 1 day of persistent Staph aureus bacteremia was associated with a relative risk of death of 1.16. So basically, each day that patients were still bacteremic increased their mortality by about 16%. So what was associated with longer duration of bacteremia? So one of the factors was MRSA. Most importantly is delayed source control. And those factors that weren't actually associated but might have thought to have been before was the actual MIC of the organism and the choice of the antimicrobial. And then also in this particular study, looking at switching from vancomycin to daptomycin was not associated with mortality. So obviously source control is a major issue. And how do we always identify the source? It was a meta-analysis that looked at lots of cases of Staph aureus bacteremia and looked at which sources were most common. So a reasonably high proportion of patients, you may not be able to find a source. Other sources that are most common would be a line in patients who are admitted for a period of time. In terms of infective endocarditis, rates kind of vary between, say, 4 and about kind of 10%. Other important ones, obviously, skin and soft tissue, which are quite common, and then lung and bone and joint. So that raises the question, do we need to perform an echo in patients who've got Staph aureus bacteremia? And at the moment, it is suggested by guidelines. But if we look at mortality, this is a large study done which looked at all patients with Staph aureus bacteremia and looked at those patients that didn't get an echo, and then looked at adjusted odds ratios of mortality for those who had an echo that was not specified, whether it was transthoracic or transesophageal, and then those that had a transthoracic and those that had a transesophageal echo. And you can see a significant mortality benefit associated with getting an echo in patients with Staph aureus bacteremia. So as I said, it is mentioned by guidelines in the ESC and the IDSA. And also just to remember that close to 1 in 5 patients with endocarditis do not have clinical stigmata. So you can't always just rely on your clinical findings or suggestions of endocarditis. You really do need to echo a lot of these patients. So generally, we'll consider transthoracic echo for all patients with Staph aureus bacteremia. For those with esophageal echoes, we'll consider high-risk patients. So those patients who maybe have a negative transthoracic echo and have embolic events, intracardiac devices, who have a high risk like IV drug users or have had previous infective endocarditis. But are there possibly some exceptions? Are there some patients you may not need an echo for? So there have been some that have been that are associated with a lower risk of endocarditis. So hospital-acquired infection. If there's no intracardiac device, no signs of endocarditis clinically, and a negative blood culture with a clearly identifiable source, In those cases, you may possibly not require an echo, although it is currently still part of guidelines. But say if you've got a patient who's with an easily identifiable thrombophlebitis with no features of metastatic infection, getting better after, say, 3 days of therapy, blood culture is negative. In those cases, you most probably don't need one. But those are really the exceptions. There are risk scores you can use. There are a bunch of risk scores that will give you an idea as to how likely endocarditis is in the setting of Staph aureus bacteremia. And you can also use some of those scores to give you an idea. So there's the predict score, a positive score, and a Versta score. You can use any of your kind of apps to have a look at one of those scores and then look at the risk of endocarditis and then choose to get an echo or not. But generally, in our setting, we do suggest that you do get an echo for all cases. What about consulting ID? Is it really worth it? Does it add anything to the management of the patient? Well, quite a few studies have shown that there's improved outcome, improved mortality in patients with Staph aureus bacteremia and ID consult, particularly an inpatient consult. So inpatient consult has been shown to be superior to an over the phone telephonic consult. And if you had to choose this is a study that's done using thousands of patients, whether you had ID consult only and echo only or appropriate therapy only, the highest benefit is actually with an ID consult. So in our hospital, every patient who has a Staph aureus bacteremia is flagged by ID, and we will go see the patient. If you have a patient with Staph aureus bacteremia, you're always welcome to consult us. So ID is still pretty important. So how do we manage it? There's a kind of useful flow that we can use. So you identify a patient with Staph aureus bacteremia, you start empiric antibiotics. We'll go through exactly which empiric antibiotics we'll do now. You obviously look for a source, look at their skin, look at the joints, look if they've got any lines, look for evidence of endocarditis, any vertebral osteomyelitis. You're going to look for any new back pain or worsened back pain or musculoskeletal pain, and look for if there's any prosthetic material. Then you'll repeat a blood culture within 48 hours, you'll organize your echo, and you'll do your imaging according to where you think the source is. And of course, you're going to consult ID as well. So what about clocks versus cefazolin for MSSA? So there'll be different, you may have worked with different consultants who will say, no, you can only use clocks. Others may be happy to use cefazolin. So the biggest meta-analysis that's been published to date shows that generally cefazolin is a reasonable alternative. So in this, they looked at 90-day mortality, which showed that there was no specific difference. So bearing in mind that a lot of this is these are retrospective studies, not randomized control trials. Hopefully we'll have a bit more data with a few of the big randomized control trials, including SNAP study, which we're going to be doing here as part of an international study. Treatment failure or relapse, we look at the bottom here, also no difference between the two. As you can see, it crosses the one in that figure. And for nephrotoxicity, actually favors cefazolin. So where there's no difference in mortality and relapse rates, there is a significant benefit in terms of nephrotoxicity as one of the major complications of penicillin therapy in favor of cefazolin. There's one issue with cefazolin, and that is the idea about an inoculum effect. So that is an increase in the MRC at a high inoculum. So in patients with a high inoculum infection compared to a standard inoculum, which would be 10 to the 7 CFUs versus 10 to the 5. There was one study done in Argentina which showed that those with a high inoculum treated with cefazolin had a poorer 30-day mortality, but that hasn't really been replicated in other studies and seems to be more a lab effect, although it is still a topic of discussion that hasn't really translated into increased mortality. And as I showed you from the meta-analysis, generally we could consider cefazolin equivalent. The other issues that we often don't have clocks. Clocks also should be given every 4 hours. It should be given, we give it every 6 hours because it's just very difficult to give patients outside of ICU a drug every 4 hours. And obviously the side effects that are associated as well. So as I said, 2 other studies didn't show the same effect. What about using vancomycin for an MSSA? I think this is an important point as well. We have this idea that vancomycin is super potent. It works for staph. It also works for MRSA. But the issue is that if you look at comparative effectiveness against clops or against cafazolin, so clops would be one of the antistaphylococcal penicillins. Use of a beta-lactam versus vanco is associated with a lower hazard ratio of mortality, and cafazolin or an antistaphylococcal penicillin also associated with significant reduction in mortality. So we don't use vancomycin for patients who we know have Staph aureus bacteremia that is susceptible. You may sometimes use it as empiric therapy if you have a patient who's got a high risk of MRSA. And some people would actually suggest even in that setting, you should combine vancomycin with cafazolin or clops if you are, because of this inferiority in the setting of an MSSA. How long should we treat for? So as I mentioned, uncomplicated Staph aureus bacteremia, we generally treat for 14 days. So this is 14 days from the last, or from the first negative blood culture. So one study looked at less than 14 days versus 14 days. Relapse rates were about 8% in those that were treated for less than 14 days, and no relapse in those that were treated for 14 days exactly. What about for treating for more than 14 days? More than 14 days, remember this is uncomplicated Staph aureus bacteremia, was associated with more side effects, but no improved mortality. So generally 14 days is kind of the sweet spot. Obviously for complicated Staph aureus bacteremia, we would generally treat for 28 days, but it also depends on the site of infection. I mean, it really just does depend on whether it's an endocarditis or whether it's a lung abscess or brain abscess. All of those would possibly have different durations of therapy, but a minimum of 28 days. We went through what was uncomplicated. So generally, patients who've got no evidence of endocarditis, no metastatic infection, get better quickly, don't have positive blood culture beyond the first one generally. MRSA. What is it? So MRSA is methicillin-resistant Staph aureus. So it was basically found or reported very soon after methicillin was actually first described. So this is in the 60s. It's resistance that is conferred by the penicillin binding protein 2A. And this is encoded by the McA gene, so you can pick it up on a PCR, where there's a gene expert for MRSA. And it confers resistance to methicillin, but also to other anti-staph penicillins. So in our setting, it's clops. Other people can use fluclops IV or oxacillin, or nafcillin. So there's a whole lot of other, but our access is to clops as antistaphylococcal penicillin. And this McA gene can be transmitted horizontally, so you can get spread of resistance within a healthcare setting, which is obviously very important. There are a bunch of drugs that treat MRSA, and it's important to remember that not all of them are drugs that you would use in a bacteremia, but are options that you could use for other forms of MRSA infection, like osteomyelitis or skin and soft tissue. Drugs that are beta-lactams, the newer ones are ceftaroline and captopril. Remember, we can use vanco, teicoplanin, linezolid, tedizolid, the other drugs that we don't really have access to. Some of the tetracyclines, DOC has got reasonable activity, Bactrim as well, and then some of your fluoroquinolones as well. The newer group of lipoglycopeptides, telavancin, dalbavancin, eritavancin, which we don't really have access to, but are quite promising as well. So these are the options overall for MRSA, but in terms of MRSA bacteremia, the most evidence is obviously for vancomycin. And for us, that's the main drug that we have access to for bacteremia. So remember, it's 15 to 30 milligrams, 12 hourly. But obviously, one of the major issues is nephrotoxicity at high trough concentrations, and that you need to monitor it very carefully. Generally via area under the curve calculations, which are a bit more difficult to do. You have to use a particular calculator, or trough dosing, which is what we do. most frequently, just because we're more comfortable with it and it's a little easier to do. But we really should be moving to area under the curve calculations. Other options would be daptomycin. So the two drugs that have got the most evidence for MRSA bacteremia would be vanco and daptomycin. Daptomycin has been shown to be non-inferior. You can't use it for a pneumonia because the daptomycin is inhibited by surfactant in the lungs. And there might be some development of resistance on daptomycin. And there's also a little bit of cross resistance for some isolates. Other options, things like teicoplanin. Teicoplanin is very similar to vancomycin in terms of spectrum. It's just got a bit of a longer half-life. It's got fewer side effects. Linezolid is an option. In terms of the data, there are some smaller studies showing it's equivalent. But generally, there's not enough evidence to use it as a first-line agent. You may consider it in cases where you can't use vancomycin and don't have access to daptomycin. There is some resistance to some isolates, so you'd have to confirm that it is actually susceptible to linezolid. And obviously, the issues with linezolid are particularly bone marrow suppression the longer you use it, so particularly for more than, say, 2 weeks. Other drugs that do have activity, like fluoroquinolones, rifampicin, Clinda, Doxy, are not drugs that you would ever use on their own for Staph aureus bacteremia. So newer drugs, there's the 5th generation cephalosporins. So ceftaroline is quite promising. We had access to it for a little while here. I don't think we generally have access to it. It's quite expensive. And then ceftobiprole, there's actually a study published in the CMJAH yesterday that compared ceftobiprole to daptomycin for Staph aureus bacteremia and found it to be non-inferior. So it's a drug to look out for. And then the other lipoglycopeptides like telavancin, dalbavancin, ritavancin are quite useful because they've got a very long half-life. So sometimes you can dose them once a week or even once a month for some of them. So they're really promising. So you could possibly, for simple Staph aureus bacteremia, give 2 doses once a week. Then the bacteriophages that have been used and endolysins as well. What about using combination therapy? We've had a few people suggest, we should add Clinda, or we should use vanco, or use cefazolin plus another drug like Clinda or Bactrim. Generally, most of the studies that have looked at using combination therapy have been smaller studies. Most of them haven't shown much mortality benefits. The one combination that seems quite promising in cases of quite resistant cases, the daptomycin plus ceftaroline, but still not a lot of evidence. So generally, combination therapy, there are potential newer options that are being investigated also in the SNAP trial. So maybe using vanco plus cefazolin, dapto plus a beta-lactam, or dapto or vanco plus Clinda. But generally, combination therapy should really only be reserved for salvage therapy. We don't really use it routinely. Then what about oral therapy? So oral therapy, there's some basic evidence now for use of oral therapy in Staph aureus bacteremia. As we know, 14 days of IV antibiotics is what's recommended. But at which point you can switch to oral therapy is a matter of debate. We know that generally we're moving towards equivalence between IV and oral therapy in certain infections. And so it's definitely something to think about. The POET trial, which is endocarditis trial, showed that partial oral therapy was non-inferior to full IV therapy in select groups of patients with left-sided infective endocarditis, but very few of them had Staph aureus, and none of them had MRSA. So it's very difficult to translate that into Staph aureus bacteremia in general. But there is some evidence to suggest that there may be an area that we're heading towards. The Sabato trial was performed recently, but still to be published. The findings were published, or at least shown at a conference last year, but we're still waiting for the official publication. So They showed that there was non-inferiority of an oral switch after 5 to 7 days of IV therapy, when they compared it to 14 days of IV therapy in a small group of patients with a low risk of complications. So those are basically your uncomplicated patients. And so the kind of prerequisite for oral therapy, which we wouldn't generally suggest yet, I don't think the evidence is quite there yet, but would be those that really have a good response, those that have got no evidence of any abscess or any metastatic infection, those that have been pyrexia free for up to 2 days and have negative follow-up blood cultures. So this is a select group of patients that's generally quite rare. But for those patients, it could be quite significantly life-changing. You could be able to get them home earlier. You reduced hospital stay, reduced complications associated with hospital exposure. So that is an area that we'll follow very closely, and I'm sure will change practice in the years to come. So how do we summarize it all? Dr. Null and Dr. Richards from Hill and Joseph have used this lime. If you've ever worked with them, they use this lime and soda kind of checklist. So I've taken their lime and soda checklist and edited it because a few of the letters didn't make sense to me. So lines, number 1L, lines. So if you've got any patient with Staph aureus bacteraemia, check their lines. If they have a line, take the line out. If they don't need a line, make sure it stays out. So we're talking mostly about central lines, but even peripheral lines if it looks like it's infected. Central lines you take out regardless, and then if you need to, you can, if they definitely need a line, replace it. That's because a line is often the source of infection, but also lines get colonized very quickly, and staph can form biofilms on the line, and so it becomes an impediment to clearing the infection. Whenever we go and do Staph aureus bacteremia consults in the wards, one of the major things we find is an incorrect dose used for clots, particularly. Patients will often use an oral fluclox. Doctors often prescribe an oral fluclox dose of, say, 500 milligrams QID, or an increased dose of cafazolin. So just be careful and make sure that the doses you're using are correct. So for clots, if it's non-infective endocarditis, it's 2 grams. We use, as I said, 6 hourly. We should actually be giving it 4 hourly, but that's really difficult. Or 3 grams if it's endocarditis. Cafazolin is 2 grams IV 8 hourly. Vancomycin, obviously, we generally monitor carefully. Your loading dose is 25 to 30 milligrams, and then 12 hourly doses of 15 to 20 milligrams, obviously adjusted for renal function. Look for metastatic infection. So when we're saying look for metastatic infection, it's doing a full assessment of the patient. Get your echo done. Look at the skin and soft tissue. You also want to look for any evidence for osteomyelitis, so feel the vertebral bodies for any tenderness that may suggest vertebral osteomyelitis. And then monitor for effervescence, so monitor for reduction in fever, monitor for a reduction in your inflammatory markers, and then remember to culture again. That's one of the other issues as well, is that we're wanting to base our duration of treatment on your negative blood culture. So often we'll come and see a patient, they had an initial blood culture, they're now a week on therapy and no repeat blood culture has been done. So we really don't know how long we need to treat that patient for. And finally, when you have patients on clox or cafazolin, you need to monitor them closely. We don't really think about the effects of penicillins. We think that they're relatively inert drugs, but anyone who's on long-term, say, clox, needs to have at least a weekly FBC and UNE, partly because they get interstitial nephritis and also because they get the hematological abnormalities, so bone marrow suppression. We had one patient who was on TAS in our ward, well, actually was in the urology ward for about a month. They consulted us because they had this pancytopenia on stopping the TAS, but obviously also beta-lactam with pancytopenia responded within a few days. So it is something that people don't often look at and should be monitored. And then obviously the risks associated with vancomycin and linezolid. We don't have access to daptomycin here, but hopefully we can get access to it soon for some of our MRSA patients. And I'd like to stop there and offer any questions.